Okay, hi again, everybody. This is Sophia DeLaviore from the Reproductive Health Supplies Coalition. Thank you so much for joining us today. I know a few people are still logging on, but I think we'll get started. So I'm going to turn it over to Heather Clark from the Population Council, who's also the chair of our New and Underused Reproductive Health Technologies Caucus. So Heather, go right ahead.
Okay, thank you very much, Sophia. Good afternoon, everyone, and thank you for this webinar today. As Sophia mentioned, my name is Heather Clark, and I'm chair of the Reproductive Health Supply New and Underused Reproductive Health Technologies Caucus, or NURHT Caucus for short. For those of you who may not be familiar, the Reproductive Health Supply Coalition, or RHSC, brings together a very diverse group of partners to mobilize in an effort to increase access to a full range of affordable, quality reproductive health supplies in low and middle income countries. It is a member-driven organization with currently over 360 members. The work that will be presented to you today has been funded by the RHSC's Innovation Fund via the NURHT Caucus. Additional support has also been received from the UN Commission on Life-Saving Commodities for Women and Children's Health. As many of you are probably familiar, the National Medicines List, or EML, is an important policy document that often dictates what the public health sector will procure for use in the health system. Today, our panel will unveil a new database called EML Search, which provides national stakeholders with information on whether 13 new and/or underused reproductive and maternal health commodities are included on the country's EML list. EML Search has been developed by the International Consortium for Emergency Contraception and the FCI Program of Management Sciences for Health. In addition to demonstrating this new EML database today, our presenters will also showcase country-level advocacy efforts in the range of these essential life-saving commodities in national EMLs. So on behalf of the NURHT Caucus and RHSC, I'm really delighted to say that EML Search has the potential to be an effective tool for country-level planning and advocacy efforts to help ensure new and underused reproductive and maternal health commodities are made available. So with that, I would like to now introduce our presenters today. And first, we have Shafia Rashid, who is Senior Technical Advisor with Family Care International Program of Management Sciences for Health. Shafia has 15 years experience working in maternal health policy and advocacy and at the global and national level. Shafia will walk us through why EMLs are important for ensuring access. Next, we have Elizabeth Wesley, who has led the International Consortium for Emergency Contraception for ICEC for the past 11 years. Currently, ICEC is hosted by Management Sciences for Health, and Elizabeth will demonstrate the EML Search database. Next, Maziko Matemba is the Executive Director of the NGO Health and Rights Education Program, or HREP, based in Blantyre, Malawi. He has led HREP as Executive Director for the past 10 years in its work on health policy and advocacy. Menziko will present on Malawi's advocacy efforts to update their EML. And finally, Sarah Rich is Senior Technical Advisor for the International Consortium for Emergency Contraception. She has more than 10 years of experience working in reproductive health and poverty reduction advocacy programs and evaluation. Sarah will present on how the EML Search can support advocacy efforts. And now I'd like to turn it over to our first presenter, Shafia, who will start us off with some background on why EMLs are important for ensuring access.
Great, thanks Heather for that introduction. I'd also like to thank the Reproductive Health Supplies Coalition, specifically the NURHT and the Maternal Health Supplies Caucuses for their support of this webinar, and as you noted, the UN Commission for Life-Saving Commodities, which also has provided financial support for this EML work. I'm going to give a really broad introduction to the concept of essential medicines and essential medicine lists and the role they play in ensuring access to life-saving commodities, medicines, and technologies. So the World Health Organization defines essential medicines as those that meet the priority health needs of a given population. Medicines or technologies are identified as essential with specific criteria, which include their relevance to public health, evidence of efficacy and safety, and cost effectiveness. Essential medicines are part of a functioning health system and are intended to be available in the right quantities, in the right dosage, with assured quality, and at a price the community and individual can afford. This graphic, which was also developed by the World Health Organization, also illustrates the concept of essential medicines. Medicines or technologies included in an essential medicine list are selective. So they represent a limited number of proven medicines and not all that are available in the market. The essential medicine list often serves as a basis for procurement and supply of medicines in the public sector, from hospitals to primary health facilities, as well as serving as a basis for medical reimbursement, medicine donations, and local medicine production. An EML, the Essential Medicine List, is a tool that can help manage public sector purchasing and distribution of medicines and the selection of quality assured and cost-effective products. However, we know that inclusion on the EML does not guarantee availability and correct use. A lot of factors can influence the availability of medicines. These include poor supply and distribution systems, insufficient health facilities and staff, and lack of adequate and inadequate financial investments in health. In 1977, the WHO, the World Health Organization, developed its first model list of essential medicines to guide national governments in selecting those medicines and technologies that best address public health needs. Every 2 years, the WHO convenes an expert committee to update the model list to reflect changes in global health, pharmaceutical developments, and patterns of drug resistance. There are two kinds of essential medicines lists, a core list and a complementary list. The core list identifies minimum medicine needs for a basic healthcare system. The complementary list includes essential medicines for priority diseases for which you would need either specialized diagnostic or monitoring facilities. The WHO model list is important because it forms the basis of national drug policy in many countries, both developed and developing countries, and governments often refer to WHO recommendations when making decisions on health spending. A country's national essential medicine list is a government-approved selective list of medicines that guides procurement and supply in the public sector. All developing countries, about 95%, have a published national essential medicine list, and 80% of these have been updated in the past 5 years. Some countries also produce or develop EMLs at the subnational or state, provincial level as part of decentralizing health services. So together with the standard treatment guidelines, essential medicine lists serve as a basis for formal education and in-service training for health professionals, and they also guide public education about medication use. So as we've noted, adding a medicine or a device to an essential medicine list does not guarantee access, nor is it the only action that's needed to ensure that these commodities reach those who need them. Being on the list, however, does clearly identify a medicine as critical for meeting public health needs and can provide leverage for advocacy if the medicine is not routinely available in the public health sector. So in some countries, national EMLs are not regularly updated and do not often include key life-saving medicines. An analysis by Hill and others in 2012 show that essential life-saving medicines for women and children are not universally listed on national essential medicine lists. For example, they looked at a number of key priority medicines from others for women and children and compared them to their inclusion on 89 developing low and middle income essential medicine lists, and found that many of them were not listed. You have the example of magnesium sulfate, which is a medicine used to treat preeclampsia and prevent preeclampsia and treat preeclampsia. It only appears on the essential medicine list of 50% of the countries surveyed. So national committees that are responsible for developing and updating the essential medicine list don't often identify or typically identify maternal and reproductive health as a national priority, and as a result, medicines and technologies for reproductive and maternal health are often left off the national list. The reasons behind these omissions are not entirely clear, but there's anecdotal evidence that shows that in some cases committees tend to focus more on therapeutic than on preventive medicines. So there are other challenges that relate to ensuring that EMLs can be an effective tool for supporting the availability and use of life-saving medicines and technologies. National EMLs are not always regularly updated, as we've seen with newer or lesser known technologies, even though these have been included on the WHO model EML. Updates to the national EMLs need to be linked to other policies that shape the appropriate use of essential medicines and technologies, including standard treatment guidelines and training curricula, both pre and in service. And we know that although a listing on the essential medicine list is a first step in making priority medicines available, there can be other factors that support their availability and use. For example, in taking the example of magnesium sulfate again, we know that magnesium sulfate is listed on the essential medicine list of Zambia, but the major barrier to availability within the public health system is because the medicine is not being procured by the Ministry of Health. Other barriers include a lack of demand by health professionals at the health center level and a lack of in-service training in the use of mag sulfate. Therefore, updates to the national EML need to be linked to improvements in the overall health system, including sound supply chains, training, and ongoing monitoring and evaluation. So I'm now going to turn over to Elizabeth Wesley, who will demo the EML Search, the new database that's the focus of this webinar that will help track essential medicines on national essential medicine lists.
Hi, thanks so much. Thank you, Shafia. This is Elizabeth Wesley. And I wanted to just demonstrate the new database, but first I'm just going to introduce the commodities that are in the database. And because this database was funded by the Reproductive Health Supplies Coalition initially and via the NURHT Caucus that Heather introduced, we included in the initial building of the database the 13 commodities that are the current NURHT Caucus focus commodities, and they're listed here. Next slide, Shafia. And then you'll see that the Commodities Commission had a broader and a different scope, and it includes some different commodities related to newborn health and child health. So the 6 reproductive health, maternal health commodities that the Commodities Commission lists are part of the NURHT Caucus, but the newborn and child health commodities are not. So if you're looking at the list in the database that I'm going to show, you'll see that's a difference. And there's certainly a chance to change the database or add commodities to the database if people feel like that would be useful. Okay, I'm ready to show the database. Okay, I hope people can see that. So this is the database. It's currently living on the Emergency Contraception Consortium website, which is cecinfo.org/EML search. And this is the page that you'll land on. We'll be sending out lots of email reminders about this URL, so you don't need to write it down right now. And you land here and you'll see that there's a little bit of description of the essential medicines lists and background about the database. And I'll just show that you can search either by country or by commodity. And as I mentioned, there's right now the 13 commodities that the NURHT Caucus focuses on. We were only able to include countries where we found the essential medicines list, and most of these we were able to find on the WHO website. Some of them are not on the WHO website and we found in other ways. We also have gotten really good feedback from users and from folks in the community. So for instance, just a few days ago we got some feedback from someone in Ethiopia that we had actually used the previous Ethiopian EML and we had not found the 2015 revision to the Ethiopian EML. So we were able to quickly go in. It's a very user-friendly backend, and we're able to make changes very quickly. So I'll demonstrate how you go in if you're searching for a country. Let's go to Ethiopia since we just updated that. And you'll click on Submit, and it'll pull up the Ethiopia page. And you'll see here that we have linked in to the actual EML. This is a PDF. So all the, so here you'll see you can open it up and you can actually see the PDF of the, so my computer's a bit slow, I'll go back. And then we start off with the commodities that are not included, and that would be something if you're in Ethiopia and you want to know what's not included, and then we list in alphabetical order the commodities that are included, the NURHT commodities, obviously not all the commodities. And you can see we've included information about, you know, what is listed, the dosages that are listed, any specific information that we were able to find in the EML for the country. We've tried to include that there. Then you can begin a new search. That takes you back to the home page, and then you can look at I don't know, let's look at oxytocin. And that will take you to the oxytocin page, and you can see that oxytocin is included in the EML of 110 countries. And there's a little description about why we have, why oxytocin is included. And then you'll see at the bottom, there's some countries that don't list oxytocin. So this might be of interest for advocates and for other people to know, like, not only where it is included, but also where it's not included. So I think that's pretty much as I need to show. We'll be having a Q&A at the end that will be done through the chat box. So feel free to start typing in the chat box right now if you have any questions about the database or about Shafia's presentation or any other presentations that are coming up. And I'm now going to introduce the next speaker, who's Maziko from Malawi, who's going to talk about some on-the-ground advocacy around essential medicines lists for maternal health commodities. Thank you.
Okay, so it seems like Maziko has actually just dropped off. I wonder if there's an internet connectivity issue. Is it possible to go ahead to Sarah's while we try to get back in touch with him?
Yeah, that's fine. That's fine, Sophia.
Okay, thanks. Go ahead, and that'd be great.
Okay.
I will make you the presenter.
Great. Whoa. Sorry, just a moment. Okay, thanks so much to RHSC for funding this project and to the Commodities Commission for adding additional funding. And I think Shafia and Elizabeth did a really great job of giving an introduction to essential medicines lists and to the database. And what I want to do is talk a little bit more specifically about how you can use the database to support advocacy efforts to update National Essential Medicines List to include all of these commodities that we have included in the database. As Elizabeth demonstrated, there are two different ways that you can search the database. One is by commodity and the second is by country. So I'm going to talk a little bit first about how you can use the commodity search function to support global advocacy. So that search function can really bring attention to specific commodities that are not included on many country EMLs. Elizabeth gave the example of oxytocin, which happens to be included on 110 essential medicines lists, but some of the other commodities that we include in the database are included on a much lower proportion of essential medicines lists. So here I've pulled up a screenshot of the database and focused on contraceptive implants in this case. We see here in the red circle that contraceptive implants are included in the essential medicines list of 44 countries, so this is a much lower number than oxytocin. And then below we can see that that means there are 76 countries that have not yet included contraceptive implants in their essential medicines lists. So I imagine that as things move forward and contraceptive implants becomes increasingly mainstreamed, this will change, but in so much as we can bring attention at the global level to this disparity, donors and others may take note, and that kind of information at the global level can then trickle down to what happens at the country level. So the search function by commodity can really highlight the gaps at the global level. The second way that our database can be searched is at the country level, as Elizabeth showed you. And this database really takes one step in the path toward advocacy at the country level, and it's really showing what the gap is in a country's national essential medicines list. So here again I have a screenshot, and I'm showing you Kenya. Kenya's essential medicines list includes several of the 13 commodities that we included in our database, but doesn't include a number of them, starting with cycle beads, diaphragm, etc. So here you can use this database to take a look at your country's essential medicines list and see which commodities are not included, which could signify the potential to do the advocacy around adding those commodities to the essential medicines list. Now, once you've taken a look to see which commodities are included in your country's essential medicines list, there are of course many factors that will determine whether or not you'd want to move forward with conducting some advocacy to update your country's essential medicines list with these commodities. And I want to talk about a few of the different dimensions that it would be critical to consider if you're thinking about conducting advocacy to update your country's essential medicines list. The first is really how important is the essential medicines list in your context. We know that essential medicines lists play a different role in different countries. They are sort of elevated to a higher level in some contexts, and in other contexts they may provide more of a background role. So in your context, how much will including these commodities on the essential medicines list really lead to improved reproductive health, access, and outcomes in your country? Another factor to look at that's part of that is, will the public sector really only procure commodities that are on the essential medicines list? We know that there's generally a relationship between including a commodity on the essential medicines list and whether or not the public sector will procure it, but it's good to make sure within your country, within your context, that that really is the case. It's also helpful to think about whether national guidelines such as treatment guidelines, treatment protocols, training curricula only include commodities that are on the essential medicines list in your context. And I've listed this last question, what other factors are important in your context, because I think there's no way to sort of sum up all of the factors at a global level, so each country, advocates in each country would need to think about what the other factors are contributing to how important the EML is in your context. Then another dimension that you would want to consider is how likely you might be to succeed in taking on advocacy to update the country's essential medicines list. And some factors to consider under that umbrella are what the time frame and the process are for updating your country's essential medicines list. So each country has periodic updates of its essential medicines list, but did your country just recently complete an update and there isn't another one scheduled for several years? Or is your country coming upon a scheduled update to the essential medicines list within the next year or two? That would certainly affect whether or not advocacy would be something that you would want to undertake at this moment. You would also want to think broadly about how favorable the policy environment is. If you do decide to move forward with advocacy, there would be quite a lot of mapping to do with specific stakeholders, but thinking more generally about whether the policy environment is favorable can help determine whether or not to move forward with a campaign. And finally, do you have resources to implement an advocacy strategy? Advocacy, of course, takes resources and takes time and takes effort, so whether or not resources are available can certainly be a determinant. If you do decide that you would like to move forward doing some advocacy around updating your country's essential medicines list, there are very many tools out there that can help you develop an effective advocacy campaign. There's no need to reinvent the wheel, and instead I have pasted here a model from Advanced Family Planning, who graciously allowed me to use their graphic, showing the 9 steps that they use to build an advocacy campaign. And you can find this these kinds of tools on advancedfamilyplanning.org. There's really no need to start from scratch. There's quite a lot of support out there for how to develop an advocacy campaign if you do decide that's the direction you'd like to move in. And finally, I do want to loop back to something that I think Shafia really highlighted, that including a commodity on essential medicines list is one step in a process of making sure that it's actually available and that women and children are able to access it, or providers provide it. So once it's on the essential medicines list, there are certainly further steps to take. Follow-up to ensure that the government is procuring the commodity is critical, for example. And then once it is procured, do providers in healthcare facilities know that it's there and that they can use it? Or if it's a demand-driven commodity like emergency contraception, is there community awareness that this is a commodity that they can get at, that people can get at these facilities? And part of making sure that it's available and used is also harmonizing the essential medicines list with other policies. So are the commodities then added into or included in standard treatment guidelines and in training curricula to make sure that the healthcare workforce in the country is trained on how to use the commodity and aware of its existence? So thanks so much. I see it looks like Maziko is back on the line, which I'm really happy to hear. And so I will turn it over to him. He's going to be providing some more in-depth information about an effort that they undertook to update the EML in Malawi.
Thank you very much, Sarah, for the wonderful presentation. As has been already said, my name is Maziko Matemba. I'll bring you the actuality of EML in Malawi. I'm Maziko Matemba. I'm Executive Director for Health and Rights Education Program. It is an advocacy organization which deals with communities and also at policy level. So in one of our strategic plan, there is issues to do with medicines and commodities. So we pursued this activity because it's part of our strategic plan, but also looking at the need, as you are aware, that Malawi as a country, we are far behind, I think, in terms of reaching the maternal mortality reduction. I think we are unable to meet the targets set ourselves that are reaching 2015, we're supposed to have 155 to 200,000. So that is a brief about my country, Malawi. So I just want to share with you, maybe you could have a glimpse, an understanding on what we have done. This is our new EML, 2015 updated. It was due to some advocacy efforts which we did in 2014 and 2015. It was a rigorous process, as my co-presenters have already said. It was not an easy process, it's too technical. It requires resources, but also it requires interest. So as an advocacy organization, I think this is what we did was not initially we did good analysis and found the problem, and also looking at the importance of the EML, more especially the 13 commodities who are very important in terms of reducing maternal mortality, neonatal and child health. So you can see now the updated list, but also the booklet itself, which has included also the standard treatment guidelines. This is the 5th edition. The last one I think was done in 2009. At the far end, I think you can see people there. These are my colleagues. Let me thank PAF, a member also of this the coalition, but also a member of the commodity commission under the Every Man Every Child, for coming up in time and supporting us to come up with developing a strategy, but also discussing more in terms of problem analysis, but also coming up with an issue. But the rest of the issues, I think we did ourselves as local advocates. And Health and RHSC program, which I head, and my CSO colleagues, we managed to rob it. So let me take you through some context. I've already said that Malawi, by 2015, we're still at 675 to 100,000, which was death maternal mortality. And contraceptive coverage is still low. More than half of all pregnancies in Malawi are dated in 2015. And we have the highest global rate of premature death. So most of also millions of women like access to basic obstetric and neonatal care. You can check this information from UNFPA, UNICEF, but also the Malawi, the Republic of Malawi. They'll tell you that we're too far to reach out to the targets which have set ourselves, but also globally. So we took this one and issued as a problem statement and started our advocacy. Our policy environment, the Malawi government is guided at international level by the following documentations, which I think most of our participants, I think on this webinar, you know, Every Man Every Child, Malawi was one of the very few countries who committed to, but also the Commission of Life-Saving Commodities, Women and Children, which I think we did our activity around, but also the Family Planning 2020, but also the Every Newborn Action Plan. So Malawi is also guided by this policy environment at global level, but at national level, we also have our own, the Malawi Growth and Development Strategy, which also has inputted some of these global commitments. So as already shared, our national EML, essential medicine list, was last updated in 2009. And in 2009, and not all, it was included all the 13 units that life savings commodities. And as already shared that I think Health and Research Education Program with other civil society, we mobilize together to a petition to government so that they should include the following: the newborn cessation device, the antenatal corticosteroids, injectable antibiotics for newborn sepsis, and also contraceptive implants to prevent unintended pregnancies. So as an advocacy organization, but also the advocates, I think we sat down and come up with a strategy where we thought it was necessary that we lobby government of Malawi to do this type of work. So some of the steps we use in our advocacy, which I think some of my colleagues have already shared on this call, on the webinar, but I will just maybe highlight some of the few which we used in our advocacy strategy to come so that we were able to come successful. Was one, we did analysis of the documentation, the standard treatment guidelines, but also essential medicine list, and we found out that it was last updated in 2009. We did only look at the EA, but also looking at the importance of the commodities which were not included. And some of them, as I already mentioned, that we advocated aggressively to Minister of Health through a petition, to the Secretary for Health, and through our petition, and they responded positively that some of the issues which we are promoting, I think, were evidence-based. So one of the issues why this is why I think we were successful, but we had evidence in our but also looking at the status of Malawi currently on issues to do with maternal, newborn, and child health. But also another thing which I think we did as was also identification of our target audience, which was the Minister of Health, and also we looked at beneficiaries as well, being women and children, As you know, Malawi, the population, the high population, about 53% of the population, are women, and they're girls and women. But also, as just shared, that we used evidence. We had a strong evidence. That's why we were able to go our own Ministry of Health and also to government in the issues of promote a message around updating the development of messages around EML. As shared, we did a petition, and we use a lot of media in our messaging, apart from the Ministry of Health itself, so that we get our issues done. So another step we use was some of the opportunities we use the media, because our organization, as an advocacy organization, we work with media regularly, but also we have the trust. The media trust our opinion in print, but also in electronic media, where our stories most of the times are covered, and we are asked a lot of, so we use also that opportunity, we saw it as an opportunity. But another opportunity also, which we identify in our advocacy, in our campaign, was the MDGSN survey, which highlighted that Malawi will not be able to meet the development goals on reducing maternal health. So we use that one as an opportunity around that. As you know, that 2015 it was also the year when I think there was a review of the MDGs. So we took also an opportunity to push an issue to that. Another opportunity, another plus in our work, which I can also share here, was that we did our campaign at a very interesting point, and most people don't even they applaud us for did what we did. Was that during the campaign when we started, it was a change of government. We had the previous government, and there was an election time. So our campaign started with the previous government. As you know, policies change after the politics change in any given country, and Malawi is not an exception. But we were able to push issues because we had evidence in it. And when the new government came in, they proceeded in terms of making sure that I think we achieved what we achieved. So through other steps which also followed through EML was the last thing which I wanted to share, which was a success story, and everyone was even astonished, was very surprised that even the media, they called us for feedback, looking at what was the feedback from the government and the Ministry of Health, is that if they have done it, because it just took about 6 months for them to start updating. As you are aware, the team which updates EML and strategy are professionals, and they also look at the resources, and this is not an easy process because it also looks at evidence from hospitals, looking at issues. So it was not an easy process, but through advocacy, but also evidence which we have, I think we're able to do that. So as some of the way forward, what we're doing now, I think as my colleagues have already shared, currently we are doing another step. Currently we are making a follow-up on the availability of the essential medicines, which I think we are included in the new EML. And I'm happy to report that most of the commodities which are in the EML, which I think we advocated them, they are supported by the donors and partners outside the country. But I'm happy to report that it has pleased the government and the Ministry of Health to include the 13 new commodities in the 2016 and 2017 National Health Budget, and they have reinforced it. We have written them a letter, we have met parliamentarians, we have met communities, we have met people, and I'm happy to report, and it has never happened, that I think having 2 successes after updating EML, and also you are advocating on the availability of medicine so that they use domestic resources, which is not an easy process to happen, I think, for a local organization to do that in a small period of time. But one of the things which I think I can make mention, I think it was issues with, I think, which I think it also being good to share to my colleagues, I think, on the call, that it's to do with the, our determination, but also the evidence which we normally use when we do advocacy. Because our organization and the partners we're working with, normally most of the times, we look at evidence first. We don't sensationalize issues. We look at evidence and share to the public, and people make a determination. So there's a trust in our public domain on how some of things we did. So it's also lending maybe to other advocates that I think we use evidence, but also the trust. We're not supposed to lose trust. So in terms of as already shared, you can see now this is where we do regular periodic check to our pharmacists and public, but also private, not for-profit hospitals. And this is a picture we recently took where we went to one of the pharmacies and looking at availability of the essential medicine list, if it is available, and if it's not available, what could be. And it is very interesting. Soon we'll be releasing another report on the sites we visited, on its availability, and also including the usage of these medicines, which is not easy process. So as I said already, we used a lot of media as well. So these are newspaper cutting. Most of our advocacy, I think they were taking the front page, which is not an easy thing. I think most of the colleagues who have done media before, they know. For you to have prominences and you look at the issues of EML, it's a new thing and it's not a sexy issue, but if the media can be able to take it as an issue and put it in front page and all the papers. In fact, when we invite media to these things, they take it very seriously and they normally put it in the front page or in pages where people can be able to see. So this is an impact we have made to our media. So we're trying also maybe to link the advocacy and the outcomes we have done in these champions advocates. As already mentioned, that we use champions in our advocacy, people who make difference, a big difference in Malawi. We carefully selected the messengers, and so that the outcome was supporting policies in place and the development strategic messaging, the improvement of improved implementation of policies, and also dissemination based on information. That was some of the strategies, some of the strategies, monitor budgetary commitments, forecasting, as already mentioned, that 2016 will be very unique year, where I think soon there'll be a pronouncement, because starting from the 1st of July, we're going to have a new budget. And I can assure you, all my colleagues, in the new budget, there will be a budget line which is going to indicate the 13 UN commodities as a link first, so that no one will ever going to abuse or use that money for other issues. So this is, I think, some of the things which we did in a space period of time, but I think it has got to do with some of our interest, our organizational advocacy strategy space, and also the evidence we normally use, and other links we have, and also relevance we as an organization we have in country. So lastly, let me thank our partners. The first logo is our organization PUB, and also let me thank sincerely, most sincerely, thanks so much PUB for trusting us. It wasn't an easy process when they selected our organization as one of the only organization in Malawi. Remember, there were other countries who also were trying to do the same things, but sadly they were not successful as we were. I'm very thankful for PUB for trusting us. We have taken together way through. They have supported us technically, financially, to make sure that we're able to get the results which I think I'm able to present. But also let me thank my colleagues in the Reproductive Material and Newborn Advocates, which work together. Maybe you saw my picture at the very beginning of this presentation, but also the media worked so hard in publicizing our stories. But also on other hand, I also want to thank the coalition, which I think there's necessity for this in a special way. It's not an easy process, inviting us to share our story. Maybe there would be others who also done the same, but I think you thought it would be important that I think as a country, as an organization, as a law organization, we can be able to share this success story. So thank you so much, the Reproductive Health Supplies Coalition, and all my colleagues on the call and the panelists, but also my presenters for giving this opportunity to speak. I'm hoping for the best. We have a lot of work to do, and if there's any other partner who want to join us on how we can proceed, because there's a lot of work to be done. Recently, as already said, we were in pharmacies checking. There are some stockouts of certain commodities, facilities, other than social supply. But we're hoping, I think, with the local budget support, which I think the government of Malawi will start procuring slowly, maybe we might make a difference. So we are ready to join us, and I'm also ready to share our story to other partners who will be willing to advocate for EML in their countries. It's not the process, but we have some experience now which we can share. This is what I want to share. Thank you so much. God bless you.
Thank you very much, Ms. Iko. This is Elizabeth again. I think Maziko did a really good job of linking the EML work with other advocacy work around budgeting and advocacy around stockouts and so on. And so I think that was a great kind of a great local example of how EML advocacy and EML lists are only part of a very big, you know, a very big puzzle around access to these commodities. I'm going to just ask the questions. It's difficult. People have been typing in questions, and I'll read them and then I'll answer them. And I know it's not very interactive, but it's very hard for us to unmute everyone when we have so many people on the line, because it just creates a lot of echo and then no one can hear anything. So you can type questions into the chat box, and hopefully we'll have time to go to all of them. The first question is from Erin Sieber, and she asked, with what frequency will the database be updated? So right now we've been able to just update. It's pretty quick for us to add in a new EML as we learn about one. So as I was mentioning, someone emailed us last week when we sent out the first email about this and said, oh, you don't have the latest for Ethiopia. So they come out, the new EMLs come out randomly, and there's no, like, I don't know of any place apart from going into the WHO website where you can easily find the latest EMLs. So I think really that this is something that we'll be asking all of you in our community to alert us as well to a new EML that's being developed or that's been published. There's sometimes quite a long delay from when a country publishes an EML to when it shows up on the WHO website. So it doesn't take us long at all to make an update. It does take us quite a long time. It took us a long time to build the database because we actually hired interns, a native French speaker, native Spanish speaker. We wanted to make sure that we read through all the EMLs with the correct language, you know, in the different languages, and that we got it right. It's really easy to make mistakes or to misread because different countries are using different terminology, and so, you know, we do have on the EML database spots where you can email us, and there's a link where you can send us an email. So if we've made a mistake or if there's a new EML for your country, please let us know. I hope that answered your question, Erin. The next one says, oh, okay, hi, this is Eric, Project Director for USAID Global Health Businesses Intelligence and Analytics Solution. Yes, that's quite a title. This database is great. Is the underlying data available through other technical means, such as an export of a file? Eric, we originally collected all the data into an Excel spreadsheet, but as we're updating it live into the back end of the database. So our Excel spreadsheet would not be useful now. We could potentially talk to our developer about putting in a little button where you could just download everything, maybe by country or by commodity. That's something that we've done in other databases. I could, you know, if people feel like that would be useful, that's something that we could probably add in. It's a functionality that can certainly be built in. So it could come out as a CSV file. Milka said she was surprised that oxytocin is not on the URL, the EML for the Uruguay, and that's exactly why we wanted to build this database, because it is, we've been also surprised by what is and isn't included in specific countries. Let's see, I have a question from Renia Coughlin. And she writes that she's interested in the issue of EML versus central medical stores selection. I would just like to add some information on the situation in Zambia. We work on the information on imports. We have an indication that oxytocin was imported by the central medical stores of Zambia every year for the last 5 years. I think that's really true, and I think that's part of the point that Maziko was making, that EML, there's not like a one-to-one relationship between the EML and public sector procurement. So, you know, the EML is one part of the access puzzle, but there's also a lot of others. We actually track access to emergency contraception in a different database, and we look at multiple different indicators, and that's absolutely true. I think it's complex at the country level, and it's complex for each commodity. So we don't want to, certainly wouldn't want to suggest that the EML is the be-all and end-all. It's just, it's part of it. The great thing about EMLs is that they're written down and published as PDFs and posted on the WHO website, so it is, you know, quite easy to build a database around them. Okay, we have a question from Eric Mele, using the example of levonorgestrel IUDs. And he asks, I'm a big fan of IUDs and of LARCs, so we did add in here, we thought it was relevant to add our IUDs, you know, our other IUDs included in the EML, because the levonorgestrel IUD is obviously a much newer method. It's in some ways would be easier to add a levonorgestrel IUD to an EML if IUDs are already included. So when we included a section, are other IUDs included, yes or no? And the other IUDs were pretty much copper IUDs, and different countries have different, list different IUDs. You would have to click into the PDF of the EML for the country. Some will say, you know, copper IUD 380A, whatever it's called, and some will just say copper bearing IUD. So there's not like one IUD that you would find that would be included in all the countries. Hope that's helpful. Okay, so Danielle Russo asks a very important question, and it's something that I addressed at the beginning. I would be interested in understanding if there is a plan to extend the products included in the database. Today it appears to include only a subset of priority products. So Danielle, that's a great point, and it's something that we've been discussing a lot as we go. We were funded by the Caucus of the Reproductive Health Supplies Coalition, so we started off with those 13 commodities that the Caucus is currently tracking. And that's not the same as the commodities that the Supplies Coalition is tracking, and it's certainly not the same as all the important commodities. The question is, you know, how big do you go? For me, looking in family planning, I would be, you know, we try and track, like some countries just don't list any contraceptives at all. So to me, that's of interest. I know people who work on child health have different interests. People who work on maternal health have other commodities that they feel are essential. So it's pretty tricky. It certainly would be possible to add new commodities into the database. The question is which ones would be the most valuable for our partners. As I say, we're really open to more discussion. I know it's hard to discuss in this format, but you can always, first of all, type in a question or a comment right now, but certainly go into the database and send an email, or you can send an email to me at uwesley@msh.org, but there is a spot in the database where you can send us an email as well. Are there any other questions? Okay, well, we're 7 minutes before our closing time, but if we don't have any other questions, I think I will turn it back to Sophia to wrap us up.
Great. Okay. Thanks so much, Elizabeth. And yeah, if you have any last questions, feel free to chat those in right now. But if you have further questions, please reach out to any of the panelists or myself at the Reproductive Health Supplies Coalition. You probably received the invitation from me. We will certainly circulate your questions to the right person. I encourage you to all check out this database, and we can circulate more information about it and make sure you all have the link to all of our listservs. Thank you so much, everybody, for joining, and there will be a recording of this webinar. I know there was a little bit of an issue with the viewpoint on Maziko's slides, so we'll pass along the recording of the webinar, hopefully with his slide deck as well, so you can follow along. So thanks for your patience, and thank you for joining us today. Bye, everyone.